Welcome to Head and Neck Oncology Journal Club. I'm your host, and today we're covering the KEYNOTE-689 trial just published in the New England Journal of Medicine. For 20 years, the standard of care for resectable locally advanced head and neck squamous cell carcinoma has been the same: surgery followed by adjuvant radiation with cisplatin added for high-risk features like positive margins or extranodal extension. Despite this aggressive approach, about a third of patients relapse within a year, and fewer than half survive to 5 years. Immunotherapy has transformed outcomes in metastatic head and neck cancer, but could it help in the curative intent setting? Keynote 689 answers that question. This phase 3 trial randomized 714 patients with resectable stage 3 or IVA head and neck cancer. The experimental arm received 2 cycles of neoadjuvant pembrolizumab before surgery, then 15 cycles of adjuvant pembrolizumab, 3 concurrent with radiation, 12 after. The control arm received standard care alone. Importantly, this was predominantly an HPV-negative population, 97%, with oral cavity being the most common primary site at 60%. The primary endpoint was event-free survival, assessed by PD-L1 status. Here are the results. In the overall population, 3-year event-free survival was 57.6% with pembrolizumab versus 46.4% with standard care alone, a hazard ratio of 0.73, p equals 0.008. The curves separated early and stayed separated. The benefit was even more pronounced in PD-L1 high expressors. For patients with a combined positive score of 10 or more, the hazard ratio was 0.66. But here's what makes this trial particularly compelling. First, neoadjuvant pembrolizumab did not compromise surgery. Surgical completion rates were essentially identical, 88% in both arms. This was a major concern going in, and it's been definitively addressed. Second, there was a pathological downstaging effect. Fewer patients in the pembrolizumab arm had high-risk features on final pathology, 32% versus 44%. This translated to fewer patients needing cisplatin, 39% versus 50%. So immunotherapy may actually allow de-escalation of toxic adjuvant chemotherapy. Third, pathological responses were seen exclusively in the pembrolizumab arm, 9.4% major pathological response, 3% complete response. What about toxicity? Grade 3 or higher adverse events were similar between arms, around 44%. The main difference was immune-mediated events, occurring in 43% of the pembrolizumab arm versus 10% with standard care. Hypothyroidism was common at 25%, but manageable. Pneumonitis occurred in 5% with 1 fatal case. Bottom line, Keynote 689 establishes the efficacy of perioperative pembrolizumab in resectable, locally advanced head and neck squamous cell carcinoma. That's your evidence distilled. See you next week.